From the JAMA Network, this is JAMA Otolaryngology Head and Neck Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Otolaryngology Head and Neck Surgery.
Hi, everyone. Welcome back to the JAMA Oto podcast. I'm your host, Dr. Paul Bryson from the Cleveland Clinic, Department of Otolaryngology and Voice Center. Before we get started today, I wanted to alert the listener that we do talk about the important yet difficult subject of suicide in this episode, which I know can be distressing. So let me say from the start that if anything you hear today resonates with you, if you need resources or support, you can go to the American Foundation for Suicide Prevention at afsp.org, and for free 24-hour support in the United States, you can call or text the number 988. Please look after yourself and enjoy the podcast. I'm delighted today to have my guest, Dr. Osazuwa-Peters from the Duke University Department of Otolaryngology and Communication Sciences, with a joint appointment in the Duke Cancer Institute. Welcome to the podcast, Nosa.
Thank you, Paul. Nice to be here.
Well, I'm excited to have you on the podcast today. We are going to talk about a number of items. I wanted to highlight a couple things. First, I wanted to go over with our listeners your research looking at the association of human papillomavirus status with suicide risk among patients with head and neck cancer. And then I wanted to transition into some other work that you're doing within your research endeavors, looking at suicide prevention and mental health awareness in our patients with head and neck cancer.
Yeah, that sounds good. Thank you. I'm looking forward to talking about all these different aspects of my work.
Well, let's start with your paper. This was in JAMA Oto earlier this year. Do you want to just tell us a little bit about human papillomavirus status and suicide risk?
Yes, thank you. So this paper was born out of an extension of the work that I've been doing in this area of research. I've been doing this area of work for a few years now. What we did with this particular study was to investigate whether tumor status, HPV or human papillomavirus tumor status, had anything to do with the risk of suicide amongst patients with head and neck cancer. Why this is important, especially in the context of head and neck cancer, is that if you broadly group mucosal head and neck cancer patients, you will just have mainly two groups. You will have individuals that have HPV-mediated disease and those who have mostly tobacco-related disease. The prognosis is different for this group of patients. We know from several studies in the last decade or so that patients with HPV-positive oropharyngeal cancer tend to do better from a survival perspective compared to those who have tobacco-related disease. So why we did this study was knowing that the HPV status itself in general has something to do with being a sexually transmitted infection itself, whether that would change the risk profile in terms of the mental health, the anguish, the pain, the concerns that patients may have that may then drive their suicide risk. The basis for that is that once HPV became an established causal factor for head and neck cancer, we saw cases where couples would argue or have concerns about the fact that there may have been some infidelity-related issues in their union. And so the question was, could that be a reason, guilt or stigma or things related to that? Could that increase the risk of suicide in this patient population?
So as you approach this, how did you go about doing it? Are these patients that are local to your cancer center, or is this a larger national database sort of inquiry?
My research has really benefited a lot from the use of publicly available data sets. And these data sets can be of different quality, but I've been very fortunate to have the SEER database that's housed by the National Cancer Institute. SEER is the Surveillance Epidemiology and End Results database, and have been using this database for a while now. Now, one thing about the SEER database is that you have some data related to the cause of death. The idea is that when a patient has cancer, they may likely die from their index cancer or a secondary cancer that may have arisen following index cancer. However, we've seen from a population level, some patients may die from other causes of death other than their cancer. The good thing about the SEER database is that it has allowed us to be able to query some of these other causes of death, including the topic we're talking about, suicide. And that has been a huge benefit to me in terms of having access to a data set that allows me to investigate a cohort of patients with confirmed diagnosis of head and neck cancer, and then also look at whether they died from head and neck cancer versus a competing cause of death, such as suicide. So for this study, what we did was that we looked at the SEER database. We looked at patients from year 2000 and followed them all the way to 2022. That was the time range of our study, but we actually just focused mostly on patients between 2000 and 2017. And we were able to look at individuals who had head and neck cancer in general, but also SEER now also has an ability for us to query individuals with confirmed cases of HPV, so HPV tumor status. So we also looked at a subset of these patients based on their HPV tumor status, using this data set and querying their cause of death if they died by suicide or if they died by their index cancer.
So, what did you find in this study? And then how do you put it into the broader context of some of the head and neck cancers that our listeners might be taking care of with their patients?
Yeah, so in general, what we found was that individuals with head and neck cancer still have a very high suicide mortality rate, whether it is HPV related. So for patients that have HPV positive head and neck cancer, or whether it is HPV negative head and neck cancer. That's just the broad message from this study. So there was a higher rate among individuals that had HPV associated disease. But after we controlled for other clinical and non clinical factors, we did not find a statistically significant difference between individuals with HPV positive oropharyngeal cancer versus those with HPV negative oropharyngeal cancer. However, when compared to the general US population, we saw that irrespective of the HPV tumor status, individuals with head and neck cancer in general still have up to 4 times higher suicide mortality rate compared to the general US population. So that's the takeaway message there, Paul. And that is the fact that it doesn't really matter whether it is HPV negative or HPV positive. The takeaway message is that when individuals have head and neck cancer, their suicide mortality risk is significantly increased compared to the general US population.
Well, it's important information. Even though you mentioned earlier that the HPV status, the patients may have better treatment outcomes and clinical outcomes, the burden of the disease, perhaps the functional deficits that can arise from treatment, it still plays a major role in the mental health of people. Moving forward from this research and looking at your broader research, have you been able to ascertain any other information that might help caregivers provide mental health resources to our patients with these conditions, or any new discoveries or lines of inquiry that you're able to share today as you look at this from a population and then perhaps at the individual level?
That's where I spend my day thinking about the next steps. I'm a cancer epidemiologist, so I always do numbers, right? I talk about the risk. I talk about how to prevent these things. I talk about how the burden in the population and things like that. But this is not just about risk. This is not just about playing with numbers. These are women and men who have fought cancer. And my philosophy is that when people are dealing with a disease that is this serious, then as people in healthcare, it's our responsibility, if possible, to provide them with as much support as possible for them to have the best outcome. And it's not just about living, but it's about the quality of life. So I really like what you said about mental health. Yes, my research has focused a lot on suicide as an outcome, but there are several steps to that. We can start with the diagnosis itself. Now, cancer is a terrible diagnosis, no matter how you want to put it, but head and neck cancer is even more so. You think about what you just said earlier, the cosmetic deficit and the anatomic, you just think about the anatomy itself. We do take for granted the fact that so much of the things we do as humans has to do with communication. We are recording this session, for example. Our smile, our ability to eat, our ability to swallow, all of these things. Think about all the things we do in the US or anywhere in the world, any culture. Most celebrations tend to revolve around food and eating and speaking. Just think about whichever one. Just take a peek, most celebrations have something to do with spending time with people and having that social aspect of life. Well, when individuals have head and neck cancer, that is one of the things that goes away first. When you lose your ability to speak, when you lose your ability to swallow, I recall one of the statements that was made to me when I got into this area of research. One patient said, "Doc, do you know what it feels like when anything you eat tastes like cardboard?" I would never forget that. It just keeps ringing in my head. So we may take this for granted, but for these patients, every food, every bite is a struggle. And if you have to live your life like that, and then when you look in the mirror and you see that what you look like does not look like the person you remember, then it's a huge mental health burden. So yes, suicide might be a very dramatic, unfortunate outcome, but there are several steps to it. And that is what my research is hoping to do. So from the anxiety that we are talking about, from the depression that might be in that space, and sometimes before people die by suicide, there may be some planning involved. There's usually thoughts, and then there's some planning involved. So are there several points of intervention? I believe so. So one of the goals I'm trying to achieve by doing this work is to create more awareness about this problem in our patient population and see what we can do as part of individuals who treat cancer or who manage the life of cancer survivors and their relatives to normalize the conversation, to have more open communication about not just suicide itself, but about any mental health struggle that patients may have. I mean, if there's one thing we've learned about COVID is the fact that we can all struggle with isolation and mental health. So we can, if there's one good thing we can take from COVID, is the fact that it's okay to ask patients, how are you really doing? Are there any struggles that you may have? Let me just quickly mention, this is really critical because the suicide risk amongst head and neck cancer patients, male versus female, is about 6-1. So males are 6 times more likely to die by suicide compared to female patients with head and neck cancer. Why is that important? Because males are also more likely to not discuss their struggles with mental health, to not discuss their vulnerabilities, so to speak, the concerns they may have. And so if the clinical environment does not provide an opportunity to really probe this question in a way that is not intrusive, in a way that patients feel empowered, they may just bottle it up, never share it, and when the opportunity presents themselves, they may take that way out. My goal is to create a platform where patients feel empowered because it's so mainstream for them to talk about their suicidal ideation or their struggles, just as they will talk about, oh, I have a headache, or I felt like vomiting because of this medication, or I have a dry mouth, things that are regularly acceptable in the clinical context. I would love for patients to be able to also talk about their mental health vulnerabilities and struggles in the mainstream environment where they feel like they can talk about that and receive the help they need.
Well, I really appreciate you highlighting this, and I commend you on your research, both present and future. And I wanted to ask, as we highlight your work here, are you aware of any information sources or any other resources that the listener might be able to explore to this end?
That's a great question. And there's been a huge global push for more recognition. The CDC has a lot of resources. And unfortunately, the recent report that came out a few weeks ago highlighted that for the first time, we're in the US not closer to the 50,000 mark in terms of the number of people who die by suicide in the US. So this is a huge problem in our community. You think about our opioid crisis, you think about the overdose and all these other things that are there. You think about access to lethal means, a lot of problems that make this something that's worth our concerted effort because there's so much that's going on in our society that will likely predispose more people to this if we don't do something as a community. So the American Foundation for Suicide Prevention, powerful organization that's been doing so much in terms of creating awareness, of funding research related to this topic, not just for individuals with cancer, but in terms of suicide in general. Now we have the three-number digit dial 988 that people can call if people are struggling or they just want to talk to someone. That's a number that you can call. And just like we have the 911, you have someone that will speak to you immediately. But it also just speaks to the fact that it starts from home, right? You can have children or support around you and still feel isolated. So it starts from building that individual network nexus, that community, that connection from your individual family unit, your social unit, your environment, being more involved in your community. And together, all of us can help support individuals who are struggling with any kind of mental health, but especially in the context of my research, individuals with head and neck cancer.
Well, I really appreciate you coming onto the podcast today and sharing this important work and this important message. And I look forward to seeing more from you in the future. So thank you so much for your time today.
Thank you, Paul.
You can find a link to the American Foundation for Suicide Prevention in this podcast show notes. This episode of JAMA Odo Podcast was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.